Hello, I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention. Welcome to this briefing on state perspectives on the 340B drug pricing program, policy trends, challenges, and future directions. This is the National Forum's second briefing on the 340B program. A recording of the first briefing, 340B drug pricing program, What You Need to Know, is available on the National Forum's website, www.nationalforum.org, together with related articles, fact sheets, and other information. This event is presented by and organized by the Value and Access Collaborative. The Value and Access Collaborative is facilitated by the National Forum and is made possible by support from Amgen, Ardelyx, BMS Pfizer Alliance, Novartis, and Regeneron. National Forum briefings aim to present multiple perspectives without bias on timely, controversial policy issues. Topics and speakers are chosen by the National Forum in consultation with nonprofit partners. We are pleased today to have Ms. Liddy Wittig as the moderator for this event. Ms. Wittig is the Director of National Programs and the HEAL Policy Center of Excellence for the Tiger Lily Foundation. Please welcome Ms. Wittig.
Thank you very much for that kind introduction, Mr. Clymer. And hello, everyone. I'm excited to be here with you all today and with this esteemed panel of experts here to share with us about the 340B program. We have a lot of great information to cover today, so we're going to jump right in. And it's my pleasure to introduce and welcome our speakers. And I'll start with Dr. Jason Aziz, who serves as the Director of Health Economics at the New Hampshire Insurance Department. His work involves healthcare price transparency with a focus on medical and prescription drug pricing. Dr. Aziz manages the New Hampshire Insurance Department's Health Class website, providing valuable information on prices, quality of care, and provider options to consumers, insurance carriers, and providers. Next, we have joining us today, Marilyn Bartlett, a Senior Policy Fellow for the Center for Health System Costs at the National Academy for State Health Policy. Before joining the National Academy for State Health Policy, Marilyn served as controller for a Blue Cross Blue Shield carrier, Chief Financial Officer for a Regional Third-Party Administrator, Montana State Employee Health Plan Administrator, and Special Projects Coordinator for the Montana Commissioner of Securities and Insurance. Next, joining us today on our panel is Shannon Dury. She's a director based in Levitt Partners, Washington, D.C. office. She provides federal policy counsel and analysis to clients, as well as assists in managing multi-sector alliances, one of which Tiger Lily is very proud to be a part of. Prior to joining Levitt Partners, Shannon worked as a senior healthcare analyst who reviewed public comments from various physician associations and individual physicians on CMS proposed regulations. Prior to these roles, she represented hospital systems in Medicare and Medicaid reimbursement matters in private law practice. And finally, joining us today is Brock Slaybach, the Chief Operations Officer for the National Rural Health Association. He was a rural hospital administrator for more than 21 years and has served on the Regional Policy Board of the American Hospital Association. He specializes in rural health system development that encompasses population health and the varied payment programs, moving rural providers into value-based purchasing models. So I'd like to welcome Jason, Marilyn, Shannon, and Brock. We're thrilled to have you join us today. Thank you again. After we hear the presentations from each of our panelists today, we'll move into a group discussion on some specific topics related to the 340B program, and then we'll turn to audience questions. So before we get started, a few quick housekeeping notes. You can all utilize the Q&A feature on Zoom to pose your questions today, and then the panelists will be able to respond after our discussion, as I mentioned. And audience members can also upvote those questions, the ones that seem especially interesting or you want to make sure get answered. And those questions will rise to the top and help ensure that they are noticed. We encourage listeners to use the chat function as well to share your perspectives or connect with each other and react to the program, but ask that you reserve the Q&A feature solely for questions today. So thank you in advance for that. Before we hear from our panelists, we'd like to get a sense of your knowledge about 340B program implementation at the state level. So if you would please take a moment to respond to the poll that just appeared on your screen, and we'll give everyone a few minutes to go ahead and do that.
All right, votes are flying in. We'll give it a few more moments.
Great.
We'll do 5 more seconds and we'll close this initial poll. And there are the results.
Great. Thank you again, everyone, for responding there to the poll. It seems like we have a pretty knowledgeable group here today. So in the interest of time, I will give just a very brief, oversimplified summary to start and let our panelists dive deeper with you. But today we're referring to and discussing Section 340B of the Public Health Service Act, which we call the 340B program. And this program requires pharmaceutical manufacturers participating in Medicaid to sell outpatient drugs at discounted prices to healthcare organizations that care for uninsured and low-income patients. This program was created in 1992 to help hospitals and clinics. And the thought is to really be able to stretch these dollars by reinvesting and reimplementing these resources for underserved communities, marginalized and minoritized communities. So through the 340B program, these eligible healthcare providers can purchase these outpatient prescription drugs at the discounted prices with the goal that these savings are then invested to improve care for underserved communities by funding patient support programs, expanding services, reducing medication costs for patients, things like this. So we are very excited to be getting into this from the patient perspective of Tiger Lily and other patient advocacy organizations. We're engaging in these conversations about how to best protect the success of the program, ensuring participating entities are using the funds as intended and that the patients in need are able to access these really wonderful resources that can be provided through this program, much of which we will hear about from our panelists today. So at this time, I'd like to go ahead and invite Dr. Aziz to kick us off. Dr. Aziz, the floor is yours.
Thank you, Lizzie, so much for those kind words and this opportunity to chat with our great audience. So, yeah, I think I'm the only state regulator here in the panel. And, with that, I chose to not produce slides, rather talk about our oversight and regulatory responsibilities to our citizens. And I mean, it's amazing what you mentioned about the 340B program and its initial intent. Back in 1992, people at the federal government had this great foresight that the marginalized and underserved population needed price relief from expensive drugs. It's amazing that, if you fast forward all these years later, we see the trajectory of prescription drug price increases. So something, early signals way back then said that this is emerging as a more and more central problem in healthcare and healthcare delivery. So kudos to the innovators who came up with this idea. Fast forward all this time, as a state regulator, we're often, how do I best say, at friction with federal regulators with, overlap and oversight and regulatory authority. We oftentimes here at the state of New Hampshire refer to that as this liminal zone between federal and state oversight, for which jurisdiction is often up for grabs. And we see that a lot in our network adequacy oversight, in our QHP plan oversight, and indeed in the 340B oversight. And every year, inevitably, we see 3 or 4 bills proposed in our New Hampshire legislature that relate to the 340B program. Some of them regard covered entities, and whereas it seems like more and more the lion's share are focused on covered drugs that are part of the 340B program. Nonetheless, it is an important program to preserve the integrity. And early on, I think before this webinar started, John mentioned this condition that he wanted this webinar to meet. This condition where we would kind of inform the audience about the intent of the 340B program being met such that it does not inhibit biological or pharmacologic innovation. I mean, that's the key tension that you see between, cost relief for these important drugs and the inhibition of financial incentives to drive innovation, to find that new cure for that new drug. I mean, I think the FDA often suffers from that same dichotomy. We want drugs to be affordable to people, but we also relegate much financial incentive to private institutions, private entities, to be financially motivated to innovate. And those two conditions sometimes are diametrically opposed. So I appreciate John bringing that up. And I wanted to bring that up because that's one of our state's initiatives to, we have a lot of legislators that are interested in the orphan drug designation part of the 340B program. And that, to what extent our viewers know about that, that also was a federal designation program for drugs for that very reason. They treated these rare conditions for which there may not have been enough revenue generating capacity for some certain drugs that treat rare conditions, but oftentimes devastating diseases. So they wanted to address those important citizens, and that's where the orphan drug designation program started. How that interfaces with the 340B program is oftentimes very complex, and it's one of the areas of state oversight that I wanted to point out. I won't mention much more about it because I think my esteemed panelists have something to say about that. The other part in the state realm, and Lizzie mentioned something about this, is the duplicate discount prohibition. I think that seems like, from a legislative perspective, like some sort of low-hanging fruit, right? Because states regulate their Medicaid programs and they're aware of the rebates and discounts that program fetches for drugs. But it's important to note that as part of the 340B program, it's prohibited for duplicate discounts for those same drugs. And that's indeed been kind of like herding cats for some states to make sure that there's sufficient regulatory oversight over that. And so I think those are the two key things that I wanted to point out about some of the challenges that we've had here in our small state of New Hampshire. And despite the small size of our state, we have several hundred covered entities registered in the 340B program. And in working on preparing for this webinar, one thing that was interesting to me is that several hospitals have multiple 340B registrations. And so that's an important, I think, finding for us, because I think it aligns with what the 340B covered entity definition relates to. So it is indeed not only a complex, longstanding program, but is one that for states is difficult to regulate and provide the appropriate oversight that our government at both the federal and state level and our citizens expect and deserve. With that, I'm going to stop there and then kind of hope that piques questions for our viewers, and let my other colleagues and panelists present some more detailed information about specific state statutes and oversight endeavors that they're participating in. Thank you.
Thank you so much, Dr. Aziz. You bring up a really great point, highlighting kind of finding this balance, right, of sufficient regulatory oversight, new innovations for patients, affordability, all great parts of 340B that we need to be talking about. Next, I'd like to hand it off to Marilyn Bartlett and let Marilyn share with us. Thank you.
Well, thank you very much. It's nice to be here. Thank you for the invitation, and I'm looking forward to learning quite a bit about this. I'm representing the National Academy for State Health Policy. We work directly with states, and we've been working with states on particular studies and legislative efforts related to 340B. So I want to cover a little bit about state actions. I think there's two important things to realize about 340B. When you read the actual law, The purpose of 340B is to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. There's nothing in there that talks about the need of the patient or some of the, and I think people think that 340B is there to serve the underpopulated or the indigent population. But the next step was that HHS, HRSA came along and defined what an eligible patient is. An eligible patient is that the covered entity has an established relationship with the patient. They maintain the records of the individual's health care. The patient receives health services from a healthcare professional who is employed or contracted with the covered entity, and the patient receives all healthcare services from there. So the actual fundamental part of 340B is that it is to stretch scarce federal resources to eligible patients, and then the eligible patient really is an insured individual, a Medicaid patient, an uninsured, whatever. But that is a crux of what states are dealing with when they look at 340B. Next slide. So we took a look at the HRSA information, and this is actually was from 2023 data of the 340B program, and this is the purchases allocation. I think it's really important to see that 78% of it are the disproportionate share hospitals, the larger hospitals. That by far is the bulk, and that's what's caused some of the rub. If you look at critical access hospitals, that's 2%. Rural referral centers, 1%. And just as a side note, rural referral centers have been some of these very, very large facilities like Cleveland Clinic. The federal health center programs, 5%. Then we have Ryan White, HIV, and then there are federal grantees such as the STD funding, et cetera, and children's hospitals. But by far, the bulk of the 340B is going to the disproportionate share hospitals. Next slide. So when we look at state actions, the first state actions started probably around 2018, 2019, and led by advocacy groups. And I've listed a couple there at the bottom. And the first thing we saw was protecting the community health centers, because PBMs and carriers started realizing that these entities were paying less for these drugs. So they changed the reimbursement schedule and would pay them less. So through these advocacy groups, model legislation was developed and passed in several states that said you cannot discriminate against the community health centers. And in some of the state legislation, they also added the disproportionate share hospitals, critical access hospitals, and other parties, that you cannot discriminate on your pricing because they're 340B. We saw bills of that nature pass in 2024 in the states I've listed here. And then right now under consideration, I've listed 4 states that are looking at that. So that was kind of the first thing we saw states dealing with. Next slide. We then saw state legislation come along related to contracted pharmacies. And the issue there was that after the ACA, prior to ACA, a covered entity could have one pharmacy. And this really worked nicely for some of the rural facilities in that they could contract with the local pharmacy because they didn't have an outpatient pharmacy. But then when ACA came along, the covered entities were allowed to have multiple contracted pharmacies. So I think we're up around 80,000 now. And we saw the PBM group and we saw pharmacy chains develop centers, a lot of them out of state, to be able to deliver the drugs. Well, then we saw a pushback and it was to limit the amount that the contracted pharmacies could do. And I think our next speaker is going to be talking a little bit about the legal side that came along with this contracted pharmacy issue. But we're seeing states put in laws that say you cannot discriminate. You have to allow, per the 340B law, that contracted pharmacies in multitude are allowed. We're seeing some of those this was in 2024, what we saw, and we're seeing some similar legislation come forward. Next slide. We're seeing states now, we've been working with, we worked with Maine and Minnesota and Washington from NASHB. They're wanting to get into transparency to find out exactly how many dollars and what drugs are passing through here. And there's a mix here. From Maine, they passed a law in 2023, and they have their initial reporting. And an annual report is to come to the Maine Health Data Organization, and the link there takes you right to that site. And the hospital is to report three things: estimated savings, but they use the AHA calculation, and the American Hospital Association calculation is the savings is what the drug would have cost at its actual cost price compared to 340B. And that's even if they never had to have the drug as inventory, that a particular pharmacy had it. But if you start talking estimated savings, I just want you to think about that, because AHA will come in with their model, which shows the savings, just that smaller amount. They're to show their use of savings, and they're to describe the program oversight. So that's available. Now, Minnesota's been the most aggressive. They passed a law that covered entities were required to report to them. They just produced their first report. It's a good report, and there's a link there to that report. And they found that 340B covered entities earned at least 630 million net revenue from the 340B program. Now, they use the term net revenue, so that would be the payment they got less any costs they had. And I, particularly as a CPA, like that net revenue amount. They think that that represents 50% of the actual revenue, as they did not collect data from doctor's office or some of the infusion centers in some of those outpatient centers. 80% of that net revenue benefited the largest hospitals. Then they also showed an estimate of 16% of the gross revenue was actually paid to external parties. You'll see that contracted pharmacies will be taking a part of that spread. And then insurance carriers and PBMs do negotiate contracts, that part of that comes to them too. There's been some questioning on that number that it may actually be higher. Washington is just in the process. They passed a law that said their healthcare authority must establish an annual reporting requirement for all covered entities participating in the 340B drug program pricing if they receive Medicaid funds. We don't have those results yet, but I think I wanted to share it with you that now we're transitioning to more transparency. And that's my presentation.
Thank you, Marilyn. Great. Just so many great things you highlighted as well. We talked about, looking at those percentages of which entities are using the 340B program, the contract pharmacies increase, and transparency, and just so much to look at there. Thank you so much for that. Next, I'd like to invite Shannon Duryea, please, to give us her presentation and educate us and enlighten us.
Great. Thanks so much, Lizzie. And thanks so much to the other panelists. Really thrilled to be talking with you all today. Before I get started, I did want to note that in the interest of the educational nature of this webinar, my comments today will be off the record and not reflective of the views of any clients that I work with, but definitely welcome your questions on the program and its operation. I did have a couple of slides. I'm not sure if you all are able to see them or if they're there we go, seeing them come up now. But, in addition to the insights that Jason and Marilyn provided, I really wanted to talk with you all today a little bit about the federal landscape for 340B legislative changes, as well as Marilyn mentioned, some of the litigation around state actions in 340B. So as Marilyn mentioned, some of this I'll kind of quickly go through this kind of introductory piece, but the 340B program is unique in its design, right? It's a federally regulated program that oversees what is essentially a transaction between two private entities, a pharmaceutical manufacturer that participates in the Medicaid drug rebate program, as well as covered entities, which you can see listed on the screen. The purpose of the program that you can see in the green box there is not actually in the statute, but it has been kind of understood over time to form part of the purpose of the program, which is really to provide covered entities, those providers, with the resources needed to stretch their scarce federal resources. So it's not a pass-through benefit to patients, though covered entities are able to take the savings that they receive from that discount and provide that to the patient's benefit in a number of ways. As we talk about some of the challenges in the 340B program and the landscape today, one important thing to keep in mind is that the program, since its inception in 1992, has grown really significantly. And that's for a few reasons. One, there have been additional covered entity types that were added to the program as a result of the Affordable Care Act. There's also been significant growth in the number of disproportionate share hospitals that participate in the program, and they are the largest covered entity type that participates, as you could see in that pie graph from what Marilyn showed. And the use of contract pharmacies or pharmacies not owned by the covered entity has also resulted in significant program growth. So as you can see on the next slide, as we think through the challenges and the landscape to date, part of these challenges are arising because of the significant growth of the program over time in ways that I think were largely unanticipated at its forming in 1992. So when we think about what are the challenges facing the 340B program in the landscape today, one important aspect to keep in mind is that the Health Resources and Services Administration, which is tasked with administering the 340B program from a federal level, has really limited regulatory authority over the program. In particular, it has 3 areas that it can regulate, including 340B ceiling price calculations, civil monetary penalties against manufacturers for overcharging covered entities, as well as alternative dispute resolution. But it doesn't have clear regulatory authority over areas such as contract pharmacy or even patient definition within the program. And so we've seen an uptick in litigation over issues like those and others as it relates to HRSA's authority. Because of some of those issues, right, we can expect to see contract pharmacies continue to be an issue to watch. States have gotten involved, as Marilyn said, in trying to protect a covered entity's ability to use contract pharmacies to dispense drugs in the 340B program. A number of manufacturers have tried to limit their dispensing through contract pharmacies without the provision of more data from those covered entities. And this tension has resulted in litigation on several fronts. Some other issues to keep an eye on as we move into 2025, there's kind of a burgeoning issue around whether or not manufacturers can demand the use of a rebate model. So rather than providing covered entities with an upfront discount, some manufacturers have expressed interest in being able to provide it as a rebate on the back end, and this has resulted in some litigation as well. Some other issues to keep an eye on, Marilyn talked about the PBMs and state actions there. PBM pickpocketing away from especially community health centers has definitely received attention. Congress has considered a number of actions to better regulate PBMs across the healthcare landscape, and 340B is no different there. So that's another one to watch. I'll also flag that, in the last couple of years, there's been some enhanced public scrutiny around the actions of certain covered entities as it relates to their use of 340B savings. So these are kind of higher profile New York Times, Wall Street Journal investigations of certain entities and their reduction of service lines, as well as, their actions against individual patients. So that's kind of worth keeping an eye on as we see, how the program is viewed and how program integrity within the 340B program is viewed. And lastly, this will be obvious based on everything I've just said and kind of what we have on the next slide, but we expect to see continued federal congressional interest along with the kind of state interest in actions on the 340B program. So two areas I wanted to flag for you today to watch in 2025. Obviously state legislation is a big one to watch, and we'll talk a little bit more about that piece. But in addition, federal legislation as well as continued litigation over the 340B program are worth keeping an eye on. In the way of federal legislation, last Congress, there were a couple of efforts towards comprehensive changes in the 340B program. There was a bipartisan Senate working group that came out with a discussion draft last February and addressed areas including codifying contract pharmacies and statute, creating a third-party clearinghouse to verify claims data, enhancing audit authority and program integrity measures from HRSA, as well as giving HRSA additional resources to oversee the program. There was also a piece of legislation from other members of Congress, which would have done a number of comprehensive changes and also had some changes related to hospital eligibility. We can also expect that, in addition to any further weighing of comprehensive changes, with Senator Cassidy at the helm of the Help Committee this Congress, and given his previous interest in the 340B program, kind of continued process around what are needed changes there, how do you enhance kind of stability in the program and program integrity. There have also been other bills introduced in the way of codifying contract pharmacy, as well as making other smaller changes to the program too. So a lot to watch on the federal legislative side in 2025. On the litigation front, I've flagged three kind of areas to watch as we move forward. One is in contract pharmacies as it relates to HRSA's federal authority. There is one outstanding case in a federal circuit court. So far, courts to date have found that manufacturers can limit the number of contract pharmacies that covered entities use for dispensing. If this court decides differently, that could trigger a circuit split, which might bring this case to the Supreme Court. There has also been some litigation filed over the use of a rebate model, including from a manufacturer that wanted to implement a rebate model and was denied by HRSA. So we'll expect to see more action on rebate models in this new administration and through that litigation. Lastly, on state actions, there's a few different cases that are going on right now, really all centering around this idea of whether or not a state has authority to regulate in the 340B program, given that it is a federal program. So far, most of the scales have tipped in the favor of state statutes protecting contract pharmacies and protecting covered entities' ability to use contract pharmacies. But there is one case out of West Virginia where there was a finding in December on a preliminary injunction, which was favorable to manufacturers. This, I think, is one of the most important aspects to watch when it comes to the legal landscape as it relates to state actions on 340B, because it really gets to states' ability to act in this program, and I think will be really, really important moving forward. Lastly, quickly here, and I know I'm a little bit over my time, so I'll be brief, but given all of the challenges that are going on in the 340B program, I did want to highlight a little bit of work that Levitt Partners is doing in this space in the 340B working table to bring together covered entities, including hospital systems, CHCs and others, to kind of find consensus around areas that would improve program stability and enhance program integrity. So if folks have any interest in that work, I'm happy to connect with them offline. But with that, Lizzie, I'll turn it back to you and happy to answer folks' questions as they come up throughout this webinar.
Thank you so much, Shannon. It was a great overview of kind of what's going on the litigation side and the legal and federal and state, looking at regulatory authority, rebate models, PBM challenges, and the uptick in litigation due to all these. So thank you. Next, I'd like to invite Brock Slaybach on, and I'll let you take it away.
Well, thank you, Lizzie. It's great to be here this afternoon for the rural presentation of this afternoon's program. Wanted to highlight several things that are really important about the 340B program and its importance in rural hospitals. First of all, rural areas make up 80% of the landmass in the United States, but we have anywhere from 17 to 20% of the population. It's really important to understand that rural areas provide all of the food, fuel, and fiber that power our nation and make it run. And so access to high quality healthcare and the services that our facilities provide is a requirement to keep these important resources available. In fact, we look at this as a national security issue. that it's important that we produce the goods and services, the food, fuel, and fiber to keep the rest of America healthy and operating. And so historically, public policy has not favored rural hospitals very well in many of the programs and services that the government operates. This has not been intentional. It's just been one of those facts of oversight many times that has occurred in this environment. And so the 340B program is an example of how important it is to the health and welfare of rural hospitals. In fact, if you were to do a poll of hospitals, the two programs that provide the most benefit to them is the 340B program, and then also the disproportionate share hospital program that many participate in, which is another government program. We've seen the stress on rural hospitals, including the closure of many since 2010. That number is 150, and you can see them distributed here on the screen and by the various types of hospitals that they represent. You can see that the largest number of hospitals that have closed are PPS hospitals, 75 out of a total of 150, or 50%. This indicates that there's a stress that's going on in many facilities around the country, and for all of these, 340B is an important element. We've had the conversion of hospitals to rural emergency hospital. We've had 32 since the program started in roughly 2023. And you can see where those are distributed here on the map. I will make a quick comment that rural emergency hospitals were not legislated to be covered entities under 340B. So when a hospital that may be 340B converts to REH, they will lose their 340B covered entity status. And then finally, nearly half of all rural hospitals operating in the United States today are doing so in the red. 46% of them are operating at a loss. And that number is greatly increased when you look at those hospitals that are in states that did not expand Medicaid. You can see the distribution of, or the concentration of hospitals that are doing poorly financially. And you can see that they largely rest in states like Kansas, Oklahoma, Arkansas, Mississippi, and Alabama. And those are states that have had problems in terms of being able to meet the needs of the hospitals in terms of their financial wherewithal. But 340B participation is pretty wide and varied in the rural space. You can see on this screen here that all 1,360 critical access hospitals are designated covered entities under the 340B program. So all they have to do is really apply to be a 340B covered entity. The other categories have to meet disproportionate share hospital requirements. And so if you are a sole community hospital, for example, you have a lower threshold for that percentage. I believe it's 8.75%. If you're not a sole community hospital or a rural referral center, that percentage is 11.75%. So you can see here the distribution of where the dollars are going to purchases that are happening by covered entity. And you can see that on the left side of your screen. On the right side is the 340B participating disproportionate share hospital type. And you can see the numbers that are participating in each of those categories. Again, 340B critical access hospitals aren't listed on the right side because all 1,360 of them are qualified. And as I mentioned earlier, rural emergency hospitals are not 340B eligible. So when we poll our members and when we ask them what is the most important problem that or concern that they have regarding the 340B program, 60% indicated that the restrictions on contract pharmacies was the most important issue in their world. This is the limitation that many pharmaceutical companies have placed on the number of contract pharmacies. And this has diminished the ability of these facilities to attract or to accrue the financial benefits. Now, someone might ask, why is it important to have multiple contracts in a rural hospital with a community pharmacy? The reason is because you might have the hospital located in one town where there's a community pharmacy, but in their service area, say a county or a two-county area, there may be multiple community pharmacies that the hospital would like to extend the program to. And so what you're doing is essentially reducing the distance that a patient would have to travel in order to get their prescription. The other side benefit to the 340B program in a rural context is that it does provide additional resources to a community pharmacy. And we've seen community pharmacies close in the last 10 to 20 years because of some of the similar financial pressures placed upon them. So often, rural community pharmacies will get a higher dispensing fee as a result of their participation in the 340B program, which helps to sustain those vital resources or outlets of service to the community. And then you can see here the discriminatory plans and pharmacy benefit manager practices. We talked to Marilyn and others have talked about this earlier, and this is a real problem for about 27% of our members. Then we get down to some of the lesser areas, patient definition for a covered entity, and then the issue of Medicaid duplicate discounts are much less in terms of percentage problem or concern for our rural members. So this is just a high-level overview of why the 340B program is so important to our members and why we have been looking at legislation to try to solve some of the problems that are occurring. We're also extremely interested in the state-based approaches that are helpful to rural hospitals in, say, Arkansas, that have been passed and now currently under litigation. We're hoping that those efforts are successful to keep the 340B program strong for our rural providers. So I'll turn it back over to you, Lizzie, for the rest of our program.
Thank you, Ragnar. We're just glad you were able to join us again. That was a great overview. Thank you so much. Really highlighting the importance of 340B for rural hospitals. We had just kind of moved on to our first discussion topic, which I think touches on a lot of what you were sharing, but looking a little more holistically at 340B, was just kind of asking, what do you all see as the most significant policy trends shaping the 340B program at the state level right now? And then the second part of that was, how do they impact healthcare providers, especially those in rural or underserved areas?
Lizzie, can I just start real quickly because it's right off the heels of what Brock was just talking about. From New Hampshire Insurance Department, we're regulators, and we're very rural. We're a rural state. But those first two concerns of the rural hospitals that Brock was talking about, that's essentially the relates to the statutes that we have here in New Hampshire that we enforce for the 340B programs, anti-discriminatory practices, and essentially anti-steering. So it was not a surprise to see there was such a high frequency of those two primary concerns among his rural cohort. But I just wanted to share that that's essentially most of what we see in terms of current legislation. We have an insurance statute and a trade and commerce statute addressing just those two topics. So I laud Brock bringing that to the forefront here.
I would say from NASHB's work with states, what we're seeing is the states really have limited authority due to the fact that it is a federal program. And several of the things that states have wanted to do would be preempted per federal law. So I'm seeing more states move towards transparency, but that has caused some issues with the administrative requirements on rural hospitals or the community health centers, that type of aspect. One of the things that I've worked on in Montana and a couple of other states was to actually leverage the 340B program for our corrections departments, that they can align with a 340B entity, and then medications for the you have to establish that eligible patient requirement with the covered entity, and then it has helped states bring in lower cost drugs for the corrections population. We're seeing some states try to maneuver within the program to how can they help their own state function better financially. But I think we're going to continue seeing states look at all of those aspects that I had mentioned, that really preserving, as Brock said, the covered or the contracted pharmacy aspect. And we see a lot of that also coming from the larger insurance companies that have some of that impact, and the also the PBMs. And then we're starting to see more come forth on transparency, and some of the transparency efforts are starting to kind of push that federal law a little bit.
Let me quickly add about one of the features of the contract pharmacy, which is so vital to not only hospital operations, but it's also important for the rural community pharmacy that's partnering with the hospital, because often they can provide higher dispensing fees to them, which then preserves access to those community pharmacies that are so vital to the community and its health status, particularly as you look at the increases that we're seeing in the high proportion of chronic disease in rural areas, that access to those pharmaceutical services are critically important.
Yeah, only other thing I would add, Lizzie, I think, Marilyn, to your points, I think we're going to see kind of continued activity around protecting the ability for covered entities to use contract pharmacies, both at the state and federal level. There's also interest in regulating PBMs, and at the state level, looking at that from, preventing clawbacks or kind of pickpocketing of certain entities from PBMs. While there is some uncertainty around, what is the actual purpose of the 340B program, I think most folks can agree that the purpose is not for PBMs to be achieving the savings rather than covered entities or individual patients. And then there's also, I think, some other state efforts around prohibiting PBMs or insurers from requiring claims modifiers or certain other identifiers too. So I think those are all important aspects to watch. And then along with kind of what challenges to some of these state laws look like will be important to watch for their impact on covered entities.
Yeah, a lot of great points, especially looking at that at PBM piece and how we're all going to get through this. And you guys touched on a lot of this already, all of you, but looking at the biggest challenges that states face in managing and implementing the 340B program, and we talked about kind of that struggle between federal and state legislation too. But looking at some of those challenges that you guys have highlighted, what are your thoughts on how stakeholders, like including both policymakers, healthcare providers, from my perspective, even patient advocacy groups, how can we all address these issues? Anybody want to?
Lizzie, I think it's a great question. There's, I think in the program there are a lot of opportunities. We've seen kind of the process at the federal level around some of these comprehensive changes to, bring more transparency and kind of program integrity measures that don't exist to date, in exchange for additional kind of stability and foreseeability in the program. And I think that there's a number of stakeholders that have a voice in bringing all of those things to bear, because, I think, Brock, as you said, there are so many entities that really heavily rely on these discounts to be able to operate and to be able to serve patients. And there are some serious program integrity concerns, concerns for HRSA's regulatory authority and their ability to oversee the program, and just some of these things that have cropped up given the kind of really large size of the program and the regulatory authority that exists today. So I would encourage stakeholders to kind of get involved in those discussions, both on the value of the 340B program and how it can be improved to make sure that it is accountable to the stakeholders it should be serving.
I love that. Thank you. Oh, Brock, sorry, I didn't mean to interrupt you. Go ahead, please.
Go ahead, Brock.
I was just going to say that at National Rural Health Association, one of the features of our work is not only to support legislation and to look for champions in Congress, and then also monitoring, of course, at the state level, the different activities of legislation, and hopefully replicate those as they may be working well to other states. But we've been collecting stories. I think storytelling is an incredibly impactful way to illustrate the value of this program. And so we have anecdotes of stories that we can share with those in Congress and others that really demonstrate, I think, how this program has been used to, again, stretch those scarce resources in a rural community to provide services that would otherwise not be available. And so that, I think, has been really helpful, and it really serves to, I think, the purpose of this of keeping this program strong.
I think one point that kind of takes the conversation the different direction, and I talk about this from my experience of administering the state of Montana employee health plan, is that when you're an employer plan and it's a 340B drug, you lose your rebate. And how it hit me was we were paying $5,000 for Humira. This was back in 2016. And all of a sudden, I lost my significant rebate. And the reason I lost my rebate is that the hospital became a 340B covered entity and the contracted pharmacies under them. So I continued to pay $5,000 and lose my rebate, and the hospital received that spread. So actually you're shifting that savings from one entity to another. And I think some states have heard that comment come back from their state employee health plan or workers' comp plans. And so I think that's something to be aware of. It is shifting the savings.
And we did have a question come in, and we're getting close to time, so but related and kind of similar to what you were just saying, Marilyn. This person, states PBMs are using access to 340B pricing to drive higher PBM margins, which we kind of touched on. One approach could be obtaining 340B pricing that allows drug purchasing at lower costs and pocketing the spread or part of the spread without delivering all the significant savings to their clients. This is clearly outside the intent of 340B. How can this be reined in? I think that's kind of what we've been talking about a little bit, and we all hope to have, but I don't know if anyone wants to respond to that again.
Well, I'd like to ask Shannon and Brock a question. What if the law were to be changed as far as the definition of eligible patient?
And changing it to, I guess I'm not tracking.
That it's not just a patient that is connected with the covered entity.
Yeah.
But that there were a different definition for patient. That would be the underserved maybe, or where you wanted that to go. What would happen then?
I can speak as a provider. Historically, I'm not in a hospital now, but I used to run one. The challenge of doing the necessary documentation to ensure that a patient is in the category that you might be mentioning is really hard. And then having to track that documentation, and then I don't know what kind of oversight there would be in terms of any kind of audit to make sure that it's all correct. We operated a charity program at my hospital, and it was incredible. We kept reducing the number of documents required to categorize someone as a charity patient because we could never get the documents to prove to prove that program eligibility. So that would be my initial answer, just in terms of the complexity.
That makes
Yeah,
sense.
I would. Oh, go ahead, Marilyn.
No, that makes sense. Thank you.
Yeah, no, I would tend to agree with Brock. I think there'd be some administrative complexity depending on how narrowly you defined the patient. And I think that, you know, given HRSA's limited authority to date, there's a reason that there's been a lot of congressional interest in further, you know, codifying a more defined definition of a patient. And there's been litigation over one entity in South Carolina and their way of defining the patient, which in HRSA's view was much broader than it should have been. You know, another way of looking at this might be not so much do you change the definition of the patient, but also do you make specific requirements on covered entities for how they treat low-income patients within their entity. So there's no one-to-one in the 340B program to say you have to take these savings and provide them directly to a patient. But as Congress, and particularly the bipartisan working group, has looked at, you know, what are some aspects of covered entities that should share if they're in the 340B program. One area they've looked at is like concrete requirements around patient assistance and a sliding fee scale. So you could attack some of the issues that way as well by saying, you know, regardless of 340B, certain patients should be eligible for certain types of assistance from a particular covered entity. And just to go back to Jim's question too, on the PBMs, I think what you're describing is the crux of the issue with PBMs clawing back savings and discriminating against covered entities, where the covered entity should be in receipt of those savings. And I think a lot of pieces of legislation, particularly at the state level, are going after that type of discrimination. And that is also under consideration on some of the 340B bills at the federal level too.
That's great. Thank you. Great question, Marilyn. And thank you, Brock and Shannon, for that too. And, you know, very interesting when we look at changing, as you suggested, Marilyn, the language, whether it's on intent, the requirements, or how we're defining patients, that can better pull that intent through for the whole program. It is something that we're all kind of looking at together. So appreciate all your thoughts and sharing that. I wanted to, because we are getting at time, move forward to our closing. But before we do that, we would love to hear from all of you in the audience one more time. So if you could please take another moment to complete a brief poll that will be popping up here in a second, just to let us know if today's session impacted your understanding of the 340B program. Your feedback is very valuable to us and helps improve future programs. So we would appreciate that. And then we'll get back.
We'll give it just a few more seconds. And here are the results.
Great. Well, thank you so much to our panelists. It looks like you've really helped our audience today get a better understanding of the 340B program as a whole. Before we say goodbye and hand this back over, any last closing remarks or thoughts from any of you that you'd like to share with the group today?
I'd like to just say one thing real quick. And we talked about the year 1992, which was when this program started. It's important to note that that preceded the Affordable Care Act. And there are many provisions, most of which are known, some of which are unknown, that actually aim to to protect those same vulnerable populations. And so that's noteworthy. And if we see, I mean, I have a sense there's a lot of confounding and maybe not, complete understanding, even at the covered entity or the covered drug level or the covered patient level, as Marilyn points out. A lot's changed since this started, and the Affordable Care Act is probably one good example of something magnificent that has maybe overlapped some of the intent of this important endeavor.
I'll quickly add to Jason's comment that it was the Affordable Care Act that expanded covered entity status to all 1,300 critical access hospitals in the country. So that was an important milestone.
I'll just add, I don't think I could learn 340B in an hour-long webinar. So if folks do have additional questions on the litigation, federal landscape, any of those pieces, please do feel free to reach out to me, and I'm happy to talk a little bit further about one of my favorite topics.
Thank you.
Thank you. And before we wrap up, just thank you again to all the panelists. The Value and Access Collaborative is grateful to have you all for sharing your time and expertise with us. And at this time, I'd like to hand it back over to John Clymer to wrap us up and take us out today.
All right. Thank you, Lizzie. And thank you, everyone in the audience, for participating in today's briefing and joining the conversation on this important topic. I want to add my gratitude to Lizzie's, to our expert panelists. So Jason Azes, Marilyn Bartlett, Shannon DeRee, Brock Slaybach, and of course, our capable moderator, Lizzie Wittig. Thank you for a very informative discussion. The slides from this briefing will be made available at www.nationalforum.org, together with other resources and articles that have been mentioned today. The briefing recording will also be made available, so please watch for upcoming briefings and feel free to suggest topics that would be of interest to our diverse audience. We value your feedback. Please take a couple of minutes right now to complete a brief survey regarding today's event. There's a link available in the chat box. And in case you miss it or don't have time at this moment, it will be emailed to you following today's event. But if you have a second, please do it right now. Thanks to the members of the Value and Access Collaborative for your input on briefing topics. And on behalf of the collaborative, thank you again to Amgen, Ardelyx, BMS Pfizer Alliance, Novartis, and Regeneron. Their financial support made this briefing possible. And now, take what you've learned today and put it to use in your advocacy efforts around the 340B drug pricing program.